Dr. McNamara is an assistant professor in the Division of Child and Adolescent Psychiatry and currently serves several roles for the Department of Psychiatry, including being the co-director and research director of the Division of Medical Psychology. He serves as the chief of undergraduate medical education and thus oversees the management of all the MDU classes offered by the Department of Psychiatry. Dr. McNamara is an internationally recognized expert in the treatment of obsessive-compulsive disorder and is the chief of the University of Florida OCD program, which offers specialized treatment for children, adolescents, and adults with treatment-refractory OCD. Dr. McNamara has published extensively on OCD as well as sleep, higher cognitive functioning, and a variety of other topics. His training includes the completion of PhD programs in both counseling and developmental psychology, an internship in clinical and health psychology, and psychology residency in the Division of Medical Psychology at the University of Florida. Thank you for doing this today, Dr. McNamara.
Thank you very much, and thank you for that very warm welcome.
We would like to thank you for taking this time to conduct the interview and providing us information on what a career in psychology is like. We like to begin all our interviews by asking the same question. What made you choose a career in psychology?
That's a really great question. Going back to when I was in high school, I was really interested in mental health, and I actually went back and forth between whether I wanted to go into a career in psychology or a career in psychiatry. And I went back and forth, and all through college completed my all of my pre-med courses, was studying to take the MCAT, was actually scoring pretty well on the practice exams, and realized that I had just really kind of fallen in love with the research that I was doing in developmental psychology, specifically looking at cognitive development, and decided to go down that road. And so I applied to graduate school and started my developmental psychology program right after I graduated from college, and really enjoyed the work immensely. One of the things that somewhat frustrated me a little bit about developmental psychology is that I don't feel like, as a profession, we do a very good job of talking to the lay community, and I feel like that's the case actually for a lot of research. So I started to become interested in more and more applied types of research. And at the University of Florida at the time, Dr. McRae was doing research with older adults and sleeping problems and cognition. And it had a real-world application that was immediately applicable to the patient that was sitting in front of me. And that really appealed to me. And so I applied to that program and was still very passionate about the developmental work that I was doing, and I do think that that has a very long-term payoff in terms of having an impact, for example, in education, which is where the research that I was working on has actually had an impact. Some of the work that we've done actually ended up getting on Blue's Clues, which was really exciting. But that process took a little bit longer, and I wasn't getting to directly see the immediate impact of it, and that became something that was really important to me as well. And so I really kind of integrated both programs and then completed both programs and got my PhD in counseling psychology. I applied for internships and, like you said, ended up in clinical psychology. And really had an opportunity that year to spend a lot of time focusing on OCD. And it was just really fascinated both by the treatment outcome aspect of it, which has always been something that I'm interested in, but then the significant improvements that we saw in the patients. 80 to 85% of the patients in our clinic had at least a 50% reduction in symptoms by the time they reached their 15th session, which I had never seen anything like that before, and just became really, really passionate about it, so excited about doing it. And to see the looks on the patients' faces was so incredibly rewarding. And then beyond that, doing research related to that to go, well, our treatment success rates are actually the best in the country, but at 80 to 85% with a 50% reduction, that's 15 to 20%, and then that aren't reaching that standard, and then there's another 50% to go. And so there's a lot of room for improvement, and that's one of the reasons that I'm really passionate about research, is that we can take something that's really good and make it even better, and then try and make it better again, so that we get to a point where for almost everybody coming into our clinic, that they're having almost complete remission is our goal. I don't know if we'll ever get there. But if we don't aim for the goal, we're certainly not going to get there. And so that to me is where my passion for research really is.
Okay. As with most medical professions, it seems there is a wide variety of types of careers a psychologist can have. Can you speak about the different career paths in psychology?
Sure, and they're actually an enormous variability. So the first distinction that I think we need to draw are the applied degrees versus the non-applied degrees. So typically when people think about somebody that's a psychologist, they think about somebody that sees patients, and that's certainly correct. However, people that complete a PhD in a psychology program, so for example, if it's in developmental psychology or cognitive psychology, they generally pursue careers specifically related to those, but they're not actually working with patients. They're doing research related to, for example, with somebody that's in development, they might be looking at theory of mind, they might be looking at factors related to education. Somebody that's in cognitive psychology might be looking at cognition. You might integrate both of them and have somebody that's looking at aspects related to cognitive development. There's also physiological, and how does the human body respond to different things and different stimuli. When are different brain waves occurring, and what does that mean? What's the significance of it in both clinical and non-clinical populations? And so there's an enormously wide variety of research psychologists that don't see patients, and that's not part of their training. They're strictly trained as researchers. Then within the applied degrees, which would be counseling, clinical, school psychology, educational psychology, those types of programs, you have the practitioners. Now, many of the practitioners are also trained to generate research. For example, in clinical and counseling psychology, in school psychology, you're trained to do research. In addition to that training to do research, you're also getting training in doing clinical work and working with patients and doing assessments and figuring out what's going on for the person that's directly sitting in front of you, and then making recommendations or even starting to implement those recommendations related to doing something to try and help the patient improve their lives.
Okay. So in your specific area, can you walk us through a typical day?
Sure. One of the things I actually really love about my job is that I don't really so much have a typical day. And that each day is unique, and I find that really exciting. So rather than my day starts at 8 and follow through, I'll just tell you about the different types of things that go on. And so on a typical day, I'll see anywhere from probably maybe 2 to 6, 7 patients possibly, and work with them related to whatever it is that's going on in their lives at a time. In general, I would say that for the vast majority, our sessions last about an hour. This isn't something where the patient comes in and they lay down on the couch and they tell me about their problems and we talk about things that their mother did to them. This isn't a lot of the things that you see on TV related to the practice of psychology are really pretty far off. Really more of what we do specifically in our clinic is cognitive behavioral therapy, which is that we're looking at what are the thoughts that the person's having, what are the behaviors, what are the emotional outcomes, how are all of these things interconnected, and where are places that we can work to make changes. So for example, if somebody is struggling with OCD, we do an assessment to figure out what are the different obsessions that the person has, what are the different compulsions that they have, and then we go, okay, so let's create a hierarchy. And a hierarchy is, way to think about it, is probably like a fear ladder, and you start off with, same way when you're trying to climb a ladder in your everyday life, you don't start at the top, you start at the bottom. This is exactly what we do. So somebody with a fear of contamination, we don't start off with them doing the scariest thing possible. We just start off with them doing something that, that would just be a little hard, but I think I could do it. So it might be touch something dirty and then not use their Germ-X right away and wait 5 seconds. Then wait 10 seconds, 15 seconds, 20 seconds, 30 seconds, a minute, 2 minutes, 3 minutes, 4 minutes. Okay, let's touch something dirtier and wait a little bit longer. Let's touch something dirtier on their list and a little bit longer. Let's shake somebody's hand or touch a doorknob or open a door. Let's go to a public bathroom and touch something in a public bathroom. So various different things. You really need to do a very good assessment with the patient about what it is that they're finding scary. So with any number of patients I've worked with that they're terrified of using a public bathroom, and you can imagine how this might be a problem for a child that's going to school and can't use a public bathroom. And so one of the things that we would do is put that on their hierarchy, figure out, well, what are the scary items in there for the person, It might be the door handle, it might be the latch on the stall door, it might be the handle on the flusher, and so with the parent, the child, we go into the bathroom, we identify what it is that's scary, and then we systematically start working toward, okay, how do we challenge these fears so that the patient can overcome them? And we work in a very systematic and a very gradual way. Never challenge the patients to do anything that I'm not willing to do myself. And that's a really important part of it, because for the patients, the challenges that they're taking on are really scary for them. And so it's incredibly important that we show them that and kind of model that this doesn't need to actually be something that's scary. So that's on the therapeutic end. I also supervise graduate students, postdocs, interns that are in the process of completing their training. And so in doing that, I'll meet with them and discuss the cases that they're seeing. And we'll talk about the different types of things that they're doing. Also work with fellows and residents of medical students, teaching them these different things and these different strategies and techniques. And that varies from anything from, it could be a few hours a day, to not seeing any students that are in that form of training that day. I work on the undergraduate courses, the MDU courses as well, so I certainly spend time doing that. Talked earlier about the research that we're doing, and I try and make sure that I spend every day I at least spend some time on research. And whether that's collecting data from participants, working with the graduate students that are amazing on our research team, working on their dissertations or their master's theses. But part of our mentoring process and our training is that we work with students on both training them clinically, but also training them to do the research that needs to be done.
Okay. How do you think working in academia is different than a psychologist who works privately?
It's really quite different. So a psychologist that works privately, for the most part, is going to be pretty much see patients whatever hours they're open, pretty much every day. They'll still have paperwork requirements where, as part of our ethical standards, we're required to complete paperwork and have progress notes and then do billing and so on and so forth. And so that's primarily the way most private clinics seem to run. In an academic setting, there's a lot more training involved, and so it's training graduate students, it's running an undergraduate research team, it's working with the physicians that we're closely affiliated with. Certainly in private practice, there might be some psychologists that are closely affiliated with psychiatrists. One of the real benefits of, I feel like, our program here is that we're incredibly close with the psychiatrists in our department, and really have a wonderful working relationship and really build upon each other's strengths. And I think that's something that is also really unique and something that you're primarily only going to get in an academic setting, and really requires, I think, excellent leadership from the top.
Okay. What do you think is the most difficult part of your job?
It's like, I think it's the most difficult, and I also think it's the most fun, and that each day is different. And so it requires multitasking skills to a significant degree. And so if, for example, we turned on my computer right now, we'd see I was grading somebody's qualifying exam, which is the exam they take as part of their graduate training. I have a manuscript that I'm reviewing open for a journal. I have probably about 50 unanswered email. I have 3 progress notes I need to review. So I have a lot of different things just open just on the computer, and so it's keeping track of everything and making sure that the quality of care that we're providing our patients and the quality of our research is still up to the proper standards.
Okay. As you touched on a little earlier, you said that your patients don't come in and lay on a couch. So since we've covered that, do you think that it's as effective as it is seen in the concepts demonstrated in TV shows? Do they come in after one session and they're okay?
So there's a lot of variability there. I've seen on certain TV programs some really actually pretty good therapeutic examples of what therapy is, and I've seen some horrible standards and horrible things put forth on TV. No matter, one of the things that's really prominent on TV, and it always bothers my colleagues and I, is that so many different psychologists are on TV are having sex with their patients, and I've been practicing for a long time now, and I know of nobody that's done that. And if you do that, you immediately lose your license. It's about the most unethical thing I can think of. But unfortunately on TV you see it a lot, and that really, really bothers us. In terms of length or duration of treatment, that really depends on a lot of different factors, from the severity of the disorder when the patient comes in. We specialize in treatment refractory OCD. We're one of the kind of last line of defense clinics, which means that people have tried treatment multiple other places and it hasn't worked. And so in a lot of ways we get cases that are people that are coming in, it's really significant. With that being said, we still meet that 80 to 85%, have the 50% reduction. Our goal with our patients is not for this to be lifelong therapy. If it's lifelong therapy, we're really not doing our job. Our goal is for this to be a short-term thing where we work with the patient to develop the skills that they need to overcome the anxiety or the depression or whatever it is that they're trying to overcome.
Okay.
Generally, though, I will add that like one session, for the most part, is not going to be enough.
Okay. So we have a class full of future medical providers who are deciding what field they want to pursue. Could you speak about how a psychologist differs from a psychiatrist and the importance of the two fields working collaboratively?
Sure. One, I would say, actually, it's really striking to me the number of patients that don't understand the distinction. And the distinction is really considerable in that psychiatrists have completed med school, they have prescription privileges, as they should as physicians. Their training is incredibly different. Most psychiatry programs actually don't provide that much training in therapy. One of the great things about the University of Florida psychiatry program is that they actually really do care about training their psychiatrists also in therapy, and so that's one of the additional parts of my job, is that I work to do that. So some enormous differences there. I would argue that for the most part with the people that are going into psychiatry, if they have a med management case, if you ask their patient, describe your psychiatrist, they're going to say, oh, that's my therapist as well. Even though the psychiatrist is doing a 30-minute med management thing once a month. And it's not really therapy, but it is, because it's a therapeutic interaction. And so those are incredibly important skills for psychiatrists to develop a rapport with someone, to tell you what it is that's going on in their life that's really troubling them, because that's not an easy thing to do. It takes a lot of courage to go into somebody's office who you have no idea who they are and reveal to them the different things that are going on in your life that's causing you pain. And that's one of the things that I feel like is actually one of the things that we share, is a mutual respect for the patients and the courage that it takes to come in. I think having a collaborative relationship is incredibly important. So with, for example, child and adolescent psychiatry, one of the things that they've done is actually ask several members of the Division of Medical Psychology to join them on their faculty, and we join them in their faculty meetings, their program reviews. We're involved in supervising the child psychiatry fellows the same way the psychiatrists are, because of different backgrounds, different training, and bringing those two things together. Trained as a researcher, working with psychiatrists who are trained in medicine, we're really able to advance medical research very, very effectively in what we do. In addition, providing assessment information is incredibly important. Providing therapeutic information about what it is that we're seeing in the patients, because generally, for the most part, psychologists are meeting with their patients much more frequently than, say, psychiatrists. And so we're able to tell them, hey, over the last month where I've seen this patient 4 times, these are the changes that we've seen. And so they know that going in when they look at our notes or when they talk to us about the patient. And so they're able to more accurately and more accurately really kind of fine-tune what they're doing on the medication front. Just yesterday, actually, Dr. Wynn, who's our medical director, I had a case I've been seeing for quite some time, and the patient had some concerns about what was happening with her medication. And so I went and asked Dr. Wynn, and he rearranged the schedule and got the patient in that day, right after she left my office, to sit down and talk to her and figure out if she was on the right medications or not. And that's a really wonderful thing to be able to provide that level of integrated care.
Do you guys ever work on research projects together?
Constantly.
Okay.
Constantly. So it's something that we really encourage. It's something we really enjoy. I just earlier today, actually, one of the windows that I closed on my computer was an IRB that I signed off on, where we were looking at weight loss in patients that are receiving a particular type of medication.
Okay. In all medical fields, integrated care is increasing, which means physicians, psychologists, nurses, and social workers are often going to be working side by side with the same patients. Can you speak about how collaborative care would work and what role a psychologist would have in collaborative care?
Sure. I think it really varies significantly depending on what are the presenting issues and what exactly it is that's going on. In collaborative care, I think one of the most important things is understanding each other's roles. What is it that I bring to the table? What are my skill set? What is the experiences that I have? What is it that I'm good at? And knowing that collectively as a team of, in my case particularly, while Dr. McNamara knows about executive functioning, he knows about sleep architecture. He can do treatments to improve people's sleep. And what he's really known for is anxiety disorder treatment. He can also treat depression. So, okay, so that's what his niche is, and that's what his skill set is. If we need somebody to do research or do statistics, that would be me. If we need somebody for a medication consult, something that's happening with their medication, something to understand what's happening at a neurological level, involving different physicians as appropriate, is certainly important. You see various different types of teams where, with this patient, with this presenting issue, this person takes the lead. With this type of patient, with this presenting issue, this type of person takes the lead. If it's something where we're needing to go out and or reaching out into the community to do something. For example, you might see social workers taking the lead. There's really a lot of variability. It really depends very much on how the team is structured, what the strengths of each member are. I think communication is absolutely essential, and mutual respect, and truly understanding this is what these people bring to the table. And so one of the things that's happened with our OCD program that has made it so much stronger, our clinic recently moved from one location to here out at Spring Hill, and one of the things that made this clinic and our OCD program so much stronger is the amazing collaborative relationship that we have with Dr. Lynn and Dr. Shapiro, who will do amazing things like get patients in that day to consult with them about the medication that they're taking. OCD is something that can go downhill very, very quickly. It's something that can be very intense. It's something that is an incredibly disabling disorder. And so if somebody is on the wrong medications, I could be the greatest therapist in the world, and we're not getting the treatment response that we would be expecting. It's a really important thing for us to be able to have that check-in, to figure out exactly what it is that's going on that medication level, because sometimes it's something that's just absolutely essential to have. And having that as a safety net is so incredibly important. The evidence with OCD treatment is that cognitive behavioral therapy with exposure response prevention is the frontline treatment. So in terms of our OCD clinic, they tend to come see us first. But in certain instances, it's like, you know what's going on here? There's something up with the medication, so we're going to have them see the psychiatry team first. Invariably, they end up seeing both sides of the team to figure out, well, is there anything that we can do to improve treatment?
Okay. Do you guys ever have disagreements about treatment options, or do psychiatrists respect psychologist therapy, like your cognitive behavioral therapy, and you equally respect the medication treatments?
Sure. I can really only talk about my experience there. I'm sure there are other places where things are different. Here I can tell you that we have an enormous amount of respect and very rarely ever disagree with the psychiatry team, and vice versa. We work incredibly well. And again, that goes to the communication process, in that we see each other every day. We talk to each other every day. We talk to each other about our patients every day. And so one of the things that happens where people aren't communicating as effectively is ideas kind of get set in and they get locked in. And then it's, oh no, you're challenging my idea. Whereas if it's something that's fluid, and it's like, okay, so this is what I'm considering. What do you think? This is what I'm thinking about. What do you think? It's a mutual process. that really is very collaborative and has really led to is just wonderful patient care.
You currently serve as the Chief of Undergraduate Medical Education. You provide supervision for therapists learning how to treat a variety of psychological conditions. You run a research lab with 40 undergraduates, and you used to serve as an undergraduate advisor for the Department of Psychology. Can you speak about the importance of mentoring in your career?
Sure. Mentoring is actually probably, in my career right now, the mentoring that I'm doing is probably one of the most rewarding things in my job. I truly love it. And so mentoring to me is the process of helping students develop research ideas. It's helping them develop their clinical skills. It's challenging them to improve whatever their skill set is. None of us are finished, including me. So I still have mentors as well. I have been incredibly blessed in my life by some absolutely amazing mentors. I can't name them all, but Dr. Berg, Dr. McCrae, Dr. Gefkin. I would add Dr. Wynn to that list now as well. I've worked with Dr. Bussing. Just some amazing, amazing people. Dr. Grader was somebody else I worked with who was one of my clinical supervisors and really helped me grow as a therapist. And so mentorship is something that's so incredibly important, and I've benefited so significantly from it. The way I run my research team is something that I basically learned from working with Dr. Berg. Everything I know about sleep treatment I owe to Dr. McCrae. Everything I know about OCD is really related to my experiences with Dr. Gefkin and aneuresis and caprices and how to treat ADHD, and the list goes on and on. How to work really effectively and collaboratively with people, and how to really try and improve our business. It's something I've learned enormously from Dr. Wynn. Dr. Bussing has helped me with NIH grants. So mentorship is something that, I'm 35, I'm still getting mentored, and that's a really good thing. And I hope I can say the same thing at 45 and 55 and 65. At the same time, the mentoring that I'm doing is something that I truly, truly love. I really enjoy working with undergraduate students and graduate students and postdocs and interns. After I leave here tonight, actually, I'm going to be calling a former postdoc that called me with a patient question just yesterday about, I'm not sure about this or this, what do you think? And to me, that's all about mentorship and developing those relationships. And again, going back to communication of being honest with people, being forthright with people, and developing those relationships where there's a lot of mutual trust is so essentially important.
What advice would you give to an undergrad who's looking to join a research lab and would like their PI to serve as a mentor?
Sure. There's a lot of different things. One, I think it really depends on what the student is passionate about. If the student is passionate about working with infants, for example, I would be a horrible fit because I don't work with infants. If somebody is passionate about working with preschool children, looking for somebody that's working with preschool kids. If somebody's passionate about working with older adults, looking for somebody that's working with older adults. So kind of the match in age group is potentially an option. If you're not so interested in necessarily one age group or another, thinking about different topics that you might be interested in. Whatever the research is that you're doing as an undergraduate doesn't need to be the same thing that you're doing in graduate school. Graduate schools, medical schools are not expecting you to continue the same research program that you had when you were an undergrad. So it's really about more so learning about the process. What's involved in the research process? What are the different things that are annoying and aggravating about the research process? Which, as a researcher, I can certainly tell you that there are things that are annoying and aggravating at times. It can also be incredibly rewarding. And what are the rewarding things about it? And then the process aspects of it, of what's involved in data collection, what's involved in recruiting participants, what's involved in doing data analysis, how do you enter the data? All of those different things are really important things to learn. In terms of working with a mentor, if I were going back to do it all again, one of the things that I would ask somebody that I was interviewing to join their research team is, who am I going to be interacting with? Am I going to be interacting with the graduate students? Am I going to be interacting with the faculty? Graduate students can be amazing mentors. I like to think that the graduate students at our lab are certainly amazing mentors, and I've seen that repeatedly, and they've won mentoring awards, as they should, because they're fantastic at it. And it's something where they interact with the grad students a lot. I interact with the students a lot. I see them at least once a week at our lab meetings, which we have weekly lab meetings. But more than that, I see them on the lab a lot. They have a workroom 2 doors down from me, and I'm here every day. So the students that are in that workroom, I see them every time that they're here. And so, and I interact with them, and I talk to them, and I get to know about them and their lives and what's going on as much as they want to choose to reveal. And it's something that is really an important part of that mentoring process, is learning about the student and caring about the student and helping them reach their goals, whatever their goals may be.
You have done a great job explaining about what a career in psychology is like. If an undergrad is interested in this career, can you provide some guidance on the types of experiences they should obtain in undergrad and the various schools of psychology they will have to choose from when pursuing a master's or doctorate?
Wow, that's a great question. So, at the University of Florida, there are 4 different programs that people can apply to for graduate school in psychology that I'm aware of. There's the school psychology program, where if you're applying to their PhD program, school psychology has both a master's, an EDS, and a PhD. And most students go for the EDS degree, which is where they practice in the schools and they do psychological assessment in the schools. Somebody that's getting a PhD degree in school psychology works with patients the same way that a clinical or a counseling psychologist would. They just have training in the school system as well. A counseling psychologist or clinical psychologist are both going to do research. They're both going to work with patients during their graduate training. The difference is the setting of where that's going to be. So at the University of Florida, the counseling program, they work with the Counseling and Wellness Center. The clinical program is actually located in UF Health or Shands Hospital, and they work with more severely disordered or struggling patients with more severe disorders in general. They're also more likely to work with kids. And so there's just a lot of variability there. There's also a wonderful counselor education program that offers a master's degree. They also have PhD options, and is one of the best programs in the country for people that are working toward a practice degree in psychology with a master's degree. And so I talked before about kind of the research side of psychology. And so within the psychology department, that would be cognitive psychology, social, developmental, physiological, and behavioral analysis as well. And behavioral analysis is also kind of unique because that's something where they're also working with patients, but it's a different type of degree. But it's also a wonderful field that does a lot with functional behavioral analysis, determining, well, what is it that's leading to this behavior, and they tend to work with people that are really pretty cognitively impaired. So there's just a lot of variability. Now, with all of that being said, I think looking for, well, who's doing what appeals to me best? And so there are numerous different books that people can get. I would recommend that they get those books and take a look through them. I highly recommend, as an undergrad, there are a couple of different experiences that are absolutely essential. Your volunteer experiences are incredibly important, because if you're volunteering, if you're trying to join a research team to work with older adults and you've never done that before, somebody that's looking to accept you is going to have some questions of how do they know they really want to do this. And so you really want to get volunteer experiences that are going to be somewhat related to what you think you might potentially want to be doing down the road. Your research experiences are about the process of research and also incredibly important. Your GPA, specifically your upper division GPA, really matters. Your personal statement, how well you fit into the program. I mentioned before, if somebody wanted to join our research team and they really wanted to work with infants that were not so good of a fit. That's not going to work out very well. So it could be an amazing student with amazing scores and personalities, a perfect match, but they want to work with infants. That's not going to fit. And so that type of thing is really going to come through in your personal statement, or how well you fit in the program. So that really is important to not only sell yourself to the program, but be honest with yourself and be honest with the program about how well you fit. The last thing is your GRE score. And your GRE score is something that really does matter, but it's also kind of like clearing the bar. If you clear the bar, you've made it, you're good. And so a lot of times students, when they're looking at applying at programs, they look at the average score and assume that that's the bar, and that's not accurate. So if an average program is taking in students with 1300 average on the GRE, they're taking some students that had a 1450. That means they're also probably taking students that got an 1150. So you don't know where those bars are for the programs. Most programs don't really tell you where their minimum threshold is. But if you're within striking range of that average, I would generally recommend that you go ahead and apply if you're a strong applicant in the other ways.
Okay. Do you have any closing remarks?
I think the most important thing is to be really honest with yourself about what it is that you want to do. I've seen a lot of students that have joined PhD programs through the years and have, in retrospect, I feel like kind of recognized that they made a bad choice because they're really interested in doing this one particular thing and they didn't need to get that PhD degree to be able to do it. And I've seen some students earn, that have gone a master's road because, no, I just strictly want to work with patients. And then it's like, I really would like to do some research, but they don't have the research training, so it makes that process much more difficult. So I think being really honest with yourself about what exactly it is that you really want to do. And then once you know what you want to do, absolutely going for it. And it's going to be a difficult process. One of my former colleagues, who I think very highly of, used to say the best predictor of grad school success was basically determination. And I absolutely believe that. We used to joke around that the people that should have gotten a perfect score on the GRE would be, you sit there, you get most of the way through, and then the building has a power failure, which sounds horrible to everybody, and your GRE score gets wiped out. They power it back up, and people have the option to continue or start taking the test over again, or they can leave and get a refund. The ones that stay and take the test are going to be the ones that would do well in grad school. Grad school is not an easy process, and it is a challenge. But at the same time, if you're passionate about what you're doing and you enjoy what you're doing, it's absolutely worth it. And you can make some amazing friends and develop some amazing relationships. I was talking about mentorship before, and that being such an amazing two-way street. Probably 100 of my former students that I knew when I was in grad school that were undergrads, I'm in touch with on Facebook. They're sending me baby pictures, and I get updates from them constantly on how they're doing and what they're up to. And, oh, I saw this type of patient today, what do you think? And that means so much to me, that those relationships continue to exist and continue to develop, and as I'm seeing them move on with their lives, as I'm moving on with my life. So it's something that if I had to do it all over again, I absolutely would in a heartbeat.
Thank you for all the great advice and for your time today.
Thank you.